Okay, hello everybody. Nice to meet you again. Let me present our next lecture of medical radiology. Today we will observe radiological imaging of urinary tract. First of all, let's remember what urinary tract, urinary system consists of. Two kidneys, two ureters, urinary bladder and urethra. Of course, all these parts should be found on different methods of radiological investigation. How? Let's observe. This diagram of kidney shows us internal structure of this organ, cortex, which is a collection of vessels that are grouped into nephrons. Medulla is the tubules that form the pyramids, and renal calyces, the initial part of collecting system, and of course large blood vessels, renal artery and renal vein. Basic methods of urinary tract radiological examination may be divided as for main and additional. Among main methods, ultrasound, CT scan, MRI, and play X-ray examination should be mentioned. First, ultrasound, usually the starting methods in urological practice. CT and MRI scan, as for other organs, can present images in very detail, and plain X-ray is of limited use, only for primary survey, to follow known stones, to check placement of catheters or stent or drains, or to finding of foreign bodies. Additional methods, because they are more old than listed above, and they are of course not in very wide use. Intravenous pyelogram, retrograde pyelogram, renal angiography, and cystography. All they need contrast enhancement. So, by the way, as for CT or MRI, contrast enhancement is also very essential. And last methods of radiological examination for kidneys is renal scintigraphy, nuclear medicine procedure with radioactive isotope. Normal findings on ultrasound examination. Kidneys should be of fairly equal size, about 9-11 centimeters in bipolar length, measured from the upper to lower pole along the renal axis. 1.5 centimeter difference in size is significant. If less, nothing special. Renal outlines should be smooth and regular. Renal texture. The heterogeneity of the cortex is the same or slightly darker than heterogeneity of a normal liver. Renal calyces are well seen as a bright heterogenic cluster centrally, easily differentiated from the cortex. Renal cortex is of even thickness throughout, about 2 centimeters. Normal ureters are not seen during ultrasound scanning. Bladder wall should be smooth and even, with a mucosal thickness of not greater than 5 millimeters. And no measurable residual urine follow micturition should be found on ultrasound scans. There are two main techniques of ultrasound examination in urinary tract. First, transabdominal ultrasound, which is used to study kidneys and ureters, and additionally prostate and lower part of urethra and back wall of the urinary bladder may be assessed with the help of transrectal examination in men and transvaginal approach in women. All these approaches shows very good resolution, predominantly used for stones, hydronephrosis, and for searching of local lesions. Ultrasound examination is operator-dependent method of study. It means that if you undergo ultrasound exam, please try to do it on the same machine and with the same operator, with the same doctor. Here, ultrasound of normal kidney, its sizes, main sizes, is presented. Length about 10-12 centimeters, width about 4 up to 6 centimeters, and thickness of parenchyma about 13-25 millimeters. And you see that parenchyma of kidney is slightly more dark than parenchyma of liver, which lies near. Plain X-ray of kidneys requires preparation. Foods that promote gas production, such as milk, fruits, and many others, should be excluded from the diet 3 days prior to the study. And besides, bowel cleaning enema before the study in the evening and in the morning for 2 or 3 hours before taking of X-ray pictures also is necessary. Of course, these procedures are unpleasant for patient, and X-ray it's not so informative for kidneys. Plain X-ray, that is the reason why most of patients and doctors prefer CT. Prepare patient position under X-ray apparatus is lying on his back, with a cassette is placed under the lower back so that it got to display both kidneys, lumbar muscles, and the pelvis to the level of pubic symphysis. Plain X-ray main findings are calcification, radiopaque structures, which may be detected with plain X-ray study, very dense, the dense of bones, and mainly calcification may be found in as a symptom of renal stones or tuberculosis. You may also monitor movement of stone from renal pelvis to the ureter with the help of series of plain X-ray films. But again and again, ultrasound and CT are enough in these cases. Contrast films, I mean plain X-ray or CT with non-ionic iodinated contrast media, which are injected prior to examination in peripheral vein, and after that X-ray or CT scans are taken, usually not more than 20 up to 60 millimeters of iodonated non-ionic contrast media is necessary, and then series of X-ray are taken on the first, fifth, 10th, 20th, 45th minutes, and maybe later. As a rule, the first 10th and 20th minutes are enough. And if excretion of contrast media is delayed, you need to take additional films on 45th and 16th minutes. What can we get after X-ray exposure? Contours of collecting system of pelvis with images of renal pelvis, both poles, superior and inferior pole of kidneys, images of superior, middle and inferior calyces, shadows of ureters are also present, and lower shadow of urinary bladder. Main fouls on contrast study by using plain X-ray films or CT scans are first contours of urinary tract, what may be and should be evaluated, contours of urinary tract, and delay of contrast excretion as a result of reduced kidney function or obstruction of urine outflow. How is it done? Again, initially plain film without contrast agent is made. After injection the contrast agent, within the first minutes, and then 10 minutes, a snapshot survey is carried out to estimate the initial part of the pelvis and the proximal part of ureter. It's so-called nephrographic phase, which shows us status of renal parenchyma. The second picture is taken after 20 minutes after injection of contrast media, and estimates location of contrast into the ureters and the bladder. It's so-called urographic phase, or imaging of collecting system. Perhaps more recent pictures may be needed, 45 minutes and even 1 or 2 hours later. It's cystographic phase, which allows to estimate excretion of urine from the bladder or severity of obstruction of urinary tract. Here are pictures, example of plain X-ray film in different phases of examination. First, initial plain X-ray film without contrast. Then, after 10 minutes, early phase of examination with images of calyces and renal pelvis from both sides, calyces and pelvis, and initial part of ureters, and in later phase taken after 10 minutes, all collecting system may be seen and assessed. Calyces, pelvises, and ureters from both sides. Remember that intravenosus pyelogram in its classic variant, or with the use only X-ray films, is not enough to make proper diagnosis. in majority of kidney problems. It's not enough, for example, for diagnosis of renal tumors. In these cases, in suspicion of renal tumors, CT study with contrast enhancement and CT or ultrasound-guided biopsy should be used. Here is an example of huge tumor of right kidney and a procedure of CT-guided biopsy. A needle is inserted into area of our interest under CT control, and when we ensure that needle is placed correctly, we take samples for cytological or morphological examination and so we have chance to confirm diagnosis morphologically. Next option is cystography, also contrast study when urinary catheter is introduced into urinary bladder and radio contrast is instilled in the bladder, and after this immediate X-ray image is performed. Cystography can be used to evaluate such pathologies as bladder cancer, vesicular ureteral reflux, bladder polyps, and hydronephrosis. It requires less radiation than pelvic CT. Of course, it's advantage of this technique, but also it's less sensitive and specific than MRI or CT. MRI or CT can give us much more information. Example of cystography and its value in diagnostic of urinary bladder lesions. For example, radiation cystitis with formation of fistula. Here is a view of the bladder with contrast media obtained during cystography, a shadow of catheter in urinary bladder, and beside this also shadow of contrast that is out of urinary bladder and is located in perivesical space as a result of formation of radiation-induced fistula. Next option of radiological study in urological practice is renal angiogram or X-ray of renal vessels. During this procedure, a special catheter is inserted through the femoral artery and advanced to the renal artery under fluoroscopic control. After this, after placement into beginning of renal arteries, serious contrast agent is injected into distended aorta or directly into renal arteries, and series of X-ray films or video may be taken. The procedure also may be CT or MRI guided, but it's X-ray renal angiogram is more simple. Here is, let's go back to this X-ray film. Here is angiographic image after contrast injection into distended aorta, opacifying both renal arteries and other renal vessels from both sides. It's normal angiogram of kidneys with very good developed vasculature of both kidneys. Renal angiography may be also used as a method for monitoring the effectiveness of endovascular surgery. For example, on initial renal angiogram, you may detect critical stenosis of left renal artery here, and after stenting of the left renal artery, lumen of this vessel became normal. The use of ultrasound and CT have reduced the need for diagnostic renal angiography. It remains useful for the following. If the evidence from other imaging methods is conflicting. Prior to interventional techniques such as angioplasty, to diagnose and confirm degree of renal artery stenosis, to search for vascular lesions such as arteriovenous fistula, angioma, or aneurysm, and to find estimate anatomical detail prior to renal transplant or suspected vascular occlusion following surgery. CT of kidneys. Image of kidney is always clear on CT, even in the native phase of the study, because of the large difference in X-ray density of kidneys themselves. It is equal to plus 40 up to 30 up to 40 Hounsfield units. At the same time, density of surrounding fat is in the range of minus 70 minus 130 Hounsfield units. So due to this fact, kidneys may be distinct very clearly from the surrounding fat tissue. The difference in densities also provide a good differentiation of renal parenchyma and renal sinus. Cortex and medulla of kidneys may be differentiated only after contrast enhancement or changed from CT for MRI. The ureters normally are visualized only in delayed phase of contrast enhancement. Here is presentation of kidneys on axial and coronal slices of CT and on three-dimensional reconstruction. As you see, both axial and coronal projections present us very good distinct images of cortex. Here and here more bright, more white, and medulla of kidneys. Here more dark structures, and on the axial slice also. Three-dimensional options, I don't think that is used to facilitate something, only to have more pleasant picture. All the information you need may be obtained directly from axial and coronal slides. Ureters on CT may be found as structures, as hollow tubes 25-30 centimeters in length and very narrow tubes, about only 3 millimeters in diameter. They are not very good seen in arterial phase of examination, as here, for example, arterial phase with contrasted aorta and ureters may be detected as a very small object of light gray color. But after opacification of ureters in delayed phase of contrast study, they become very clearly visible from both sides. Advantages of CT techniques. First of all, it's a detection of radio-opaque and radiolucent calculus. I didn't say that some calculi are not contrast for are not opaque for X-ray, plain X-ray examination, and maybe not seen if you are restricted only with plain X-ray. But in case of CT, radiolucent calculi became visible. Diagnosis of urinary obstruction and its level. Searching of congenital abnormalities. Detection and what is most important, correctly staging of urinary system neoplasms. Differentiation between cystics and solid urinary neoplasms. Also, such option as CT urography and CT angiography in renal stenosis and vascular abnormalities are very important and informative. MRI of urinary tract is the most important technique in uroradiology because it needs no exposure to X-ray. Of course, it's advantage of this study. It has a good diagnostic value in virtually all kinds of urinary tract disorders. Any problem, any pathology may be found on MRI study of urinary tract. Kidneys on MRI present a clear differentiation of renal parenchyma 2 cortex and medulla layer. Cortex produce hyper intense magnetoresonance signal, and medulla, on the contrary, hyper intense MRI signal. MRI allows to obtain good visualization of renal vessels, ureters, and bladder wall. Also gives the possibility of paramagnetic contrast enhancement, and special techniques such as magnetoresonance angiography and perfusion MRI also are very informative and very nice, I should say. For example, how kidneys look like on MRI scan in T2 and T1 weighted imaging, and in axial projection, and in coronal slides here. And this is normal kidneys, T2 and T1 weighted imaging. And here, example of bilateral renal ectopia. You see shadow of, not shadow, image of right kidney should be a little up, somewhere here, and of course left kidney should not be found right in the center of pelvic cavity. Also, its normal position is somewhere here, near the spleen. Special techniques as MRI, angiography, and urography, as I have said, very nice option and very informative. When we may take angiograms or urograms without injecting of any contrast media. It is based on the physical principles of MRI study. If MRI images is images of hydrogen atoms, or in other words, molecules of water, we may ask computer to choose this technique of study, and in the case of magnetoresonance angiography, blood in aorta and renal arteries, and in MRI urography, urine in collecting system of urinary tract act as natural contrast agents. So you may evaluate vascular structure of kidneys and status of collecting system without use of any contrast media, additional use of any contrast media. But enhancement is needed in some cases, and usually it is paramagnetic contrast agent such as gadolinium. They have unpaired electrons which create small local magnetic fields in the surrounding tissue, and in this way lead to shortening of T1 relaxation time in surrounding tissue, and as a result increasing the signal intensity and tissue contrast. If normally areas of our interest in this particular case, kidneys are dark on T1 images, after injection of contrast media of gadolinium, images of kidneys become brighter, and allows to assess the function of renal vessels, and to enhance lesion for diagnostic purposes, especially to find very good vascularizated tumors. Limitation or requirements for paramagnetic contrast studies in MRI techniques. Blood flow should be sufficient enough to deliver contrast agent into kidneys, and compromised capillary basement membrane is also necessary. Interventional radiology, a kind of surgery, but non-invasive surgery. When, for example, special probes or electrodes for radiofrequency ablation are inserted into previously detected tumor of kidney, then the position of This probe is confirmed by CT scan after the placement of electrode, and when we ensure that the probe is inserted correctly, we heat it up to 100 degrees or even more, and destroy tumor cells in this way. Here is an example of ideal result after 6 months after radiofrequency ablation. Here is tumor of right kidney before radiofrequency ablation and 6 months after the procedure. On post-procedure scans, we observe only delayed pelvis of kidneys, but no signs of tumor cells, tumor tissue. Kidney function may be evaluated during a nuclear medicine procedure called nephroscintigraphy. Its image contrasts by tissue uptake and metabolism. Usually, radioactive tracer, radioactive isotope of technetium is bounded to special molecule. In this particular case, bounded with molecule of dimercaptosuccinic acid, which will deliver our radioactive tracer to kidneys. Normally, technetium in combination with DTPI or DMSA is used in static renal scintigraphy, and it accumulates on renal cortical proximal tubal cells. Scanning is started immediately after intravenous injection of radiopharmaceutical. What is radiopharmaceutical? It's combination of radioactive tracer with special molecule, which has affinity to, in our case, to kidney parenchyma. Normal curve of clearance of radiopharmaceutical is presented here. Usually it arises up to peak during first 5 minutes after injection of radiopharmaceutical, and then slowly drops down, and half-time excretion usually is observed on 8 up to 12 minutes of examination. If later, it is a feature of kidney insufficiency or obstruction of urinary flow in kidneys. How is it look? What does it look like on images? I mean nephroscintigraphy. Here, image of right kidney, green color, is quite normal size, and intensivity of accumulation of radiopharmaceutical is very high. On the contrary, on the opposite side, left kidney is diminished in size, and accumulation of radiopharmaceutical is decreased. This may be shown not only as pictures, but also as graphics, and in this case of presentation, we will observe normal curve of left kidney, accumulation and excretion of radiopharmaceutical, and on the contrary, a renogram of affected left kidney does not reach normal peak and become flat. And evacuation, you see, is also delayed. Some pathologies, more frequent pathologies of urinary system, let's observe different pathologies briefly. First, chronic pyelonephritis. It's infection, inflammatory process that affects the kidneys, and this is the most common urological disease. Women, young adults suffer from pyelonephritis about 5 times more than men. This pathology is often associated with kidney stones. But I will not show you any picture, no ultrasound, no X-ray, no CT, no MRI, because all these methods of radiological examination presents only non-specific symptoms, nothing special. So they cannot be used for confirmation of diagnosis of chronic pyelonephritis. And the main diagnostic procedures are clinical features, urine analysis, and bacteriological urine culture. These are basis of diagnosis of chronic pyelonephritis. Tuberculosis of kidneys usually shows as total or local calcification on plate X-ray film, on CT, on MRI, anywhere. It's a result of long of tuberculosis which was developed in the kidney long ago. The final stage of tuberculosis in kidneys, as in many other organs, is calcification, local or total. Kidney stones or urolithiasis, characterized by formation of stones in urinary system in different parts, in kidneys, ureters, and bladder. Patient with kidney stones, up almost half of all patients who seek urological care. Here is example of so-called Stockholm kidney stone in morphological sample and in play X-ray film. So we see from both sides huge amount of calcification in both kidneys. Radiological features of kidney stones on ultrasound, X-ray, excretory urography, retrograde pyelography, or CT is the same. It's direct visualization of stones in any parts of urinary system. For example, here a picture shows the shin, shows us where pelvic stones may be found. And here X-ray films presenting stones in left kidney, in the middle of left ureter, in the terminal part of right ureter, and in urinary blood. Next pathology is hydronephrosis. Hydronephrosis is caused by obstruction of urine flow from the kidney. It means literally water inside the kidney and refers to the distension and dilation of pilocalicial system. Main causes of hydronephrosis are prostate diseases such as benign prostatic hyperplasia or prostate cancer, bladder diseases such as tumors, stones, or bladder neck sclerosis. Also, diseases of the urethra as strictures, stones, carcinomas, and foreign bodies. Also, medication or alcohol or post-operative complication or diabetes mellitus also may cause hydronephrosis. Stages of hydronephrosis. First initial stage is only pelvic dilatation. Then in second stage, except pelvic dilatation, calyceal enlargement develop, and it may be combined with possible little parenchymal reduction. And in third stage, pelvic dilatation with calyceal enlargement and parenchymal atrophy, all these signs are present on ultrasound pictures, CT films, MRI images, and so on. Main radiological features of hydronephrosis on ultrasound, CT, MRI, and other radiological techniques is dilation of renal pelvis system of varying degrees, the thinning of renal parenchyma, and in renal scintigraphy, hyperisostenouric or a functional type of curve, so-called flat curves of renal scintigrams. And methods of examination which are printed in light gray colors are additional. You may read what they allow to distinguish, but it's really not very essential. Their validity is not very essential. Plain X-ray film, two examples of excretory urograms with hugely enlarged pelvis of kidney from one side, on the right here, and on the left here, and on the right here, with the level of obstruction in initial part of ureter here, and in the middle part of ureter here. MRI, example of stenosis of right uretero-pelvic at the level of right uretero-pelvic junction, or here, and hydronephrosis of upper parts of collecting system of kidneys. And CT also is very helpful in assessment of the effect of hydronephrosis and its degree, its stage. Here is accumulation and contrast medium, accumulation and excretion of contrast medium by renal parenchyma is timely on the left kidney and ureters are completely free from urine and from contrast media, and this excretion on the affected side on the right is reduced. And here is shown the level of urinary obstruction. It's lower part of right ureter. Foreign bodies may be occasional findings on plain X-ray films. It may be parts of medical instruments, for example, fragments of catheters in men's urethra or in urinary bladder, but also unusual findings may be found, such as strange object in men's urethra, for example, magnetic beads or even screws. Renal cysts, another very common pathology of urinary system. Renal cyst means collection of fluid in the kidney. Sizes of these cavities filled with fluid vary from 1 millimeter to 10 centimeters. Up to 1/3 of individuals greater than 50 years old may have simple renal cysts that cause no symptoms. The majority of cysts are benign, simple cysts that may be monitored with periodic ultrasound and do not require surgical treatment. However, in suspicious for cancer, they may be removed by operation, by surgical procedure called nephrectomy, total removal of kidney. Radiological features of renal cyst, what may we find on CT and ultrasound images are the follows. First of all, it's homogeneous of structure, then higher than water attenuation mass, clear smooth contours with no signs of invasion into adjacent renal parenchyma. Normal parenchyma is present between the cysts, and simple renal cysts do not accumulate contrast media. And renal neoplasm, on the contrary, are very good contrasted after use of iodinated contrast media. Classification of renal cysts was proposed by Bosniak in 1986 and is in use up to nowadays. I think it's no need for me to comment in very details all the signs, to read all the signs of renal cysts of different stage. We should remember that categories 1 and 2 are so-called non-surgical and requires no treatment. Usually it's only occasional findings that produces no symptoms. On the contrary, categories 3 and 4 requires surgery. It's so-called surgical cysts. Subgroup 2F is moderately complicated cyst masses that require only follow-up, usually with ultrasound imaging, to demonstrate stability and therefore benignity of these lesions. Renal cancer, the most common type of kidney tumor, particularly the tumor of renal parenchyma. So-called renal cell cancer represents up to 80% of all cases of renal neoplasms. And the rest, 20% are epithelial tumors of renal pelvis and ureters. They are much rarer than tumor of parenchyma, and represent only 1/5 part of all cases of renal cancer. Generally, kidney tumors in adults represent not more than 3% of all malignant tumors. So it's not very often pathology. Men suffer more frequently, approximately twofold, than women. And the predominant age of patient ranges from 40 to 60 years. Methods of diagnostic of renal cancer. Ultrasound, CT, MRI allow to visualize the tumor node with fuzzy, rough, hilly contours, assess invasion into renal capsule, infiltration of surrounding fat, or invasion of the adrenal gland. Renal scintigraphy will show so-called cold focus or lack of radiopharmaceutical accumulation in affected areas. Everything that you see in light gray colors are additional methods and may be used only in combination, may be proved by main methods such as ultrasound, CT, or MRI, or renal scintigraphy. Renal cancer, its presentation on ultrasound picture, large tumor mass which is near the simple cyst. Here is simple cyst in dark color, and here is tissue structure. This is fluid, and this is tissue in tumor node. Great lesion of right kidney on CT, multinodal tumor with irregular contours of different density, with signs of necrosis somewhere. More dark is features of decomposition of tumor, of its spontaneous spontaneous decomposition. MRI also allows to confirm presence of tumor in right kidney as here. And at last, renal scintigraphy with technetium, normal accumulation on the right side and lack of accumulation of radiopharmaceutical in the upper pole of left kidney. Here, normal parenchyma is affected by tumor. It's non-functional parenchyma. No normal nephrons are here, but only tumor tissue, and that is the reason why radiopharmaceutical is not concentrated in upper pole of left kidney. Bladder cancer. CT and MRI allows visualization of the tumor node, again as in case of kidney cancer, with fuzzy rough hilly contours, infiltration surrounding perivesical fat, invasion into the adjacent organs as uterus, rectum, or prostate. Should be confirmed, these radiological findings should be confirmed by cystoscopy with biopsy for morphological verification, for establishing of tumor type, morphological type, and rest methods as plain X-ray or contrast studies with plain X-ray are of no help. Example of bladder cancer on CT scan here, normal urinary bladder with thin and regular smooth walls, and on the contrary, bladder cancer presents infiltration of posterior and right bladder wall, infiltration by by tumor with irregular and contours and multinodal tumor. Another type of bladder cancer may show only thickening of the bladder wall, for example, of left wall in this case, and no tumor lesion. It depends on type of growth of tumor, infiltration of mucosa and submucosal space, or formation of tumor nodes. So local against diffuse lesion, different types of bladder cancer growths. To know more about imaging of urinary tract, you will have a chance if follow these links. These are films about diagnostic procedures in urinary system problems, and also look through abdominal imaging, because if we perform CT or MRI of abdominal cavity, of course, we cannot evaluate only status of kidneys and ureters, and to close our eyes on problems of spleen, liver, gastrointestinal tracts, and other organs of abdominal cavity. So, thank you. This leaf falls tell us that our final exam will be soon, in December. It's very good news. Thank you for attention, and I am waiting for you at next presentations.